Thank you very much for that kind introduction. Actually, I will talk briefly about that training grant and about research and projects I performed during that training. But first of all, let me briefly tell you where I'm from. I'm from Łódź in central Poland. I work in pediatric hospital, Polish Mothers Memorial Hospital. We perform around up to 300 interventional catheterizations, 450 surgeries. We do have quite significant population of hypoplastic left heart syndrome patients. Norwood is the traditional first stage treatment. In patients with higher risk, we also perform a hybrid first stage. So this is our interventional team with two active colleagues and one senior professor. Okay, so bilateral pulmonary artery banding with or without ductal stent implantation has become an interesting and viable alternative for initial treatment of hypoplastic left heart syndrome or hypoplastic left heart complex. And it goes back to 90s to the first reports of Dr. Gibbs. Then, as you probably know, that group abandoned the idea. Then it was rediscovered by the Gießen group and also in Loma Linda. However, with different approach, in Gießen group, they do bilateral pulmonary artery banding and then percutaneously implant stent, whereas, for example, the Columbus group performs combined banding and ductal stenting. And another approach is to do the banding and keep the patient on prostaglandin infusion. But that is pretty much known. Today I would like to take my time to present on two aspects. So first one is equipment, what's new in equipment, and second one, what's new in imaging. So as I mentioned, I did the interventional fellowship in London, and I need to give full credits to Professor Goreczny and Professor Rosenthal. The research I'll show you was conducted at Evelina. They performed hybrid in a similar fashion to Columbus group, so bilateral pulmonary artery banding and stent implantation to arterial duct through direct pulmonary artery puncture. However, in London and in many other centers, we use stents. We borrow stents from other disciplines, so we don't. Until recently, we didn't have specialized or specific stent invented for ductal stenting in hypoplastic left heart syndrome. And at around 2013, it was at Evelina, the program shifted to introduction of self-expandable sinus superflex stent. This is open cell design stent made of nitinol. Can be introduced over a 4 French delivery system, so it can be introduced either through femoral vein or femoral artery or through pulmonary artery during true hybrid procedure, and it goes over 018 wire. It has got something like anti-jump system, which in our experience is completely unreliable. However, there are other also factors that contribute to the fact that the stent sometimes may not end up where you want it to end up. When we started using that stent, the available diameters were from 4 to 9 millimeters, and length was up to 20. Currently, there are longer stents available. And we looked at 24 patients who received sinus superflex stent for initial hybrid palliation. We implanted 39 stents. Median age was 7 days, median weight 2.8 kilograms. And as you may see, in 9 patients, we implanted 1 stent, whereas in 15 patients, we had to implant 2 stents. And it was due to the fact that only 20 millimeter in length stents were available at that time. However, we did not find any significant hemodynamic compromise in those with 2 stents, apart from the fact that they had longer stents or 2 stents were longer in the duct, and they had higher radiation exposure. And in the follow-up, in that group, 4 patients required re-interventions due to previously implanted ductal stent. 2 patients had retrograde aortic arch obstruction. That was treated by implantation of a balloon expandable coronary stent. And 2 patients had ductal stent obstruction. And in this case, we also used a balloon expandable stent, as seen on these images, Palmas blue stent. So in conclusions, we stated that the sinus superflex in our initial experience was effective in keeping the duct patent because of the limited availability of longer stents. We had to use 2 stents in a significant number of patients. However, further study were needed to assess results against balloon expandable stents. And that's what we did more recently. So we compared self-expandable sinus superflex stent with balloon expandable, mostly Palmas Genesis stents, Palmas blue stents. And as you can see on these images, our highly sophisticated bench testing. So that's wedding ring of Dr. Gareth Morgan hanging on 2 stents. On the right, you can see self-expandable stents. So you can see that the stent more or less aligns to the curvature of the duct, or at least try to imagine that. Yep. And on the right side, you can see that that's a balloon expandable stent, and with the same weight hanging on the stent, you can see that the stent is straight. So we compared 69 patients who underwent hybrid ductal stenting from 2005 to 2014. And that's been published, electronically published early this year. So in the first group of patients with balloon expandable stents, there were 41 neonates, and they received 43 stents. And in the more recent group, in 28 neonates, 47 patients received self-expandable stents. In general, results in both groups were comparable. However, we could see in our data, we could see that self-expandable stent is not as strong as the balloon expandable stent, and that is commonly known. However, that did not create any significant hemodynamic consequences. Also, additional intervention at the index procedure were similar in both groups. There were some differences in like intubation time or ITU stay, but bear in mind that we compare here 10 years of experience, so early experience versus the late experience and the most recent experience. And stent-related complications. Here we have some interesting observations. So in balloon expandable stents group, 9 patients, stent-related complications occurred in 9 patients, including 1 death, whereas in self-expandable stents group, there was only 1 complication, and that was a minor complication. So looking at the follow-up, reinterventions were more common in those with self-expandable stents, although we did not see statistically significant relevance, and survival was also better in those with self-expandable stents. However, once again, we compare here 2 areas of treatment. And we concluded that self-expandable stents produce favorable results with similar additional intervention rate and follow-up reinterventions when compared to balloon expandable stents. However, the balloon expandable stents produce more complications. So that first part of my presentation was about equipment. Now I would like to talk a little bit about imaging. So that's the typical angio that is taken in at Evelina. You can see a sheath placed in the main pulmonary artery, a lot of contrast going in. Still, we have to decide where the origin of pulmonary artery is and where the retrograde aortic arch is. I think it may be difficult in only one projection, so we have to make certain assumptions. And therefore, limitation of 2D angiography like structures foreshortening, overlay, lead to assumptions regarding, for instance, the origin of retrograde aortic arch. So once I came back from fellowship back to Łódź, where we have 3D RA option, and we have been doing it since 2010. So we decided to use this modality also in a small patient, 15-day-old critical aortic stenosis, borderline left ventricle after pulmonary artery banding. And we presented that intervention as a live case during 3rd European Symposium on 3D array. So that was our protocol. As I mentioned, we do it percutaneously, so we have more or less the Gießen approach to hybrid first stage. And we were planning to inject contrast to the duct through over 4 seconds. Here you can see rotational angiography, a spin from REO 120 to LAO 120. 12 milliliters of contrast. Initially, we used pure contrast. Later, we switched to diluted contrast. But I guess you would agree with me that we have plenty of projections there, plenty of information regarding right and left pulmonary artery and the setup of the retrograde aortic arch. If you look at the right image at the right side, so it's typical image taken, typical 2D image. So you see, we may make some assumptions regarding pulmonary arteries, but where the retrograde aortic arch is, it's probably difficult to say. So, but with 3D array, we also have the 3D reconstruction. You have to bear in mind that during a study, the patient is on the table, anesthetized, so we have to be quick. Therefore, with the reconstruction we don't really focus on the most beautiful images. We just want to cut out irrelevant structures and focus on the target lesion. So that's what we do here. White arrow indicates origin of the left pulmonary artery, and here the dashed arrow indicates the cutout slice near the origin of the retrograde aortic arch. So at the end we have that type of 3D model. We overlay it on fluoroscopy, and we can have all the information that we need. So left pulmonary artery, retrograde aortic arch, and ductal narrowing. And so we don't give any more contrast. We use that roadmap for stent positioning. You might notice that in the descending aorta, the delivery system is outside our 3D reconstruction. So this is a typical thing we see when we introduce stiff wires or delivery systems. But if you focus on the stent actually aligns well with the curvature of the 3D reconstruction. And you can see the indentation there. So we aim to start stent deployment at that level, and then we pull back. And this time, anti-jump mechanism worked. Okay, let's move on. So here is the example of exit 3D array. Rotational angiography gives us a lot of information again, and in addition we have 3D reconstruction here presented as a maximum intensity projection. So let's just focus on those 2D images, typically let's say left lateral and PA projections. On lateral you can see that maybe the stent is protruding to the descending aorta, but in the PA projection you can see that there's a wide entrance to the retrograde aortic arch. And 3D reconstruction gives us additional information about the correlation between the stent and retrograde aortic arch, right pulmonary artery, or left pulmonary artery. So this case and several other cases we described in your intervention, we compared 3D guided ductal stenting with 2D guided ductal stenting. Accurate 3D reconstruction overlay was achieved in all patients. All but one received self-expandable stents, and we are able to avoid contrast injection during stent positioning in all cases. Some people argue that rotational angiography carries high radiation exposure. If you look at the last 2 lines, so our rotational angiography radiation exposure composed around 13% of the total radiation dose. So with modified protocols, radiation is quite low with rotational angiography. It depends on the system, but it may be from 2 to 3 regular angiographies. And we compared these more recent patients with an earlier group of patients guided with 2D angiography done on the same system. So the older group was actually older at the age of intervention, and more frequently they had also balloon septostomy. So maybe therefore they had a higher contrast, radiation exposure. However, contrast was the same in both groups. Therefore, we concluded that the 3D array provides extensive visualization of the duct and surrounding structures. It gives us reliable landing zone for the stent. And in our experience, we didn't need to give additional contrast, and radiation dose was lower for 3D guidance. And one more thing that I would like to highlight with this paper. So many people, if they do 3D array, they start with single ventricle patients, but at the different stages. So after Glenn, after Fontaine, so with low velocity flow. And I think that in this experience, we could show that 3D array may be helpful also in high velocity flow and in small structures. So that's another key point. And at the end, I would like to show you some of our one of our most recent case. So since 2 years, we've been using vessel navigator. So we combine, or we incorporate CT images or MRI images to create 3D models. The important point is that we can do those models before the patient is in the lab. So for all small patients, critically ill patients, that's very important. We can plan the procedure, we can take measurements, and we can, for instance, mark landing zone. Everything can be done before the patient is brought to the lab. And here is the example of hypoplastic left heart syndrome after pulmonary artery banding. We put 2 blue rings to mark a landing zone. You can see 2 more rings indicating pulmonary artery bandings. These are not that relevant for the ductal stenting, so we remove them and we just leave the MPA duct and descending aorta. We use bony structure to align the 3D volume. In our early experience, we also gave a small amount of contrast. But here you can see that we implant the stent with no contrast injection, and we aim at the 2 ring markers to position the stent. And that's final result. So I presented something new about equipment, something new about imaging, but there are plenty of other new things in hybrid treatment, but my time is probably up. Thank you very much.